Urethral Catheter Infection Prevention by Maura Hargis, Liberty University. The purpose of this presentation is to review information pertaining to urethral catheters and introduce a new protocol that will help nurses promote the early removal of these catheters. The most common hospital-acquired infection in the United States is catheter-associated urinary tract infections, or as we know them, CAUTIs. It is estimated that some 40% of all healthcare-associated infections are caused by urinary catheters. A large percentage of these are caused by the use of an indwelling catheter. The Centers for Disease Control Prevention state that the prolonged use of catheters is one of the major causes of CAUTIs. They also provide information that shows CAUTIs have been a cause of increased mortality and morbidity, higher days of stay for patients, and an added cost to care delivery. The American Association of Critical Care Nurses also shares that a catheter-associated urinary tract infection is one of the most common infections a person can contract in the hospital. Catheter-related urinary tract infection occurs because urethral catheters inoculate organisms into the bladder and promote colonization by providing a surface for bacterial adhesion and causing mucosal irritation. The presence of a urinary catheter is the most important risk factor for bacteriuria. Once a catheter is placed, the daily incidence of bacteriuria is 3 to 10%. Between 10 and 30% of patients who undergo short-term catheterization develop bacteria and are asymptomatic. Healthcare-associated infections are a huge threat to patient safety. The Centers for Disease Control is active in gathering and using data to detect infections and develop new strategies of prevention. This is important in the promotion of infection prevention. The information gathered by the CDC has led to improvements in clinical practice, medical procedures, and continues to be a driver behind the ongoing development of evidence-based infection control, guidance, and prevention success. As nurses, it is in our standard of practice to use the best available evidence, including research findings, to guide practice decisions. Hospital-acquired infections are a continual challenge to quality care, and evidence is growing that many are avoidable through the use of best practices. At our facility, we have seen an increase in the number of Foley days, and with that, an increase in the number of infections. Anthem Quality Insights Hospital Incentive Program, or as we know it, QHIP, is a performance-based reimbursement program that can have a large financial impact on our facility. Their mission is to improve patient outcomes and promote health care value by financially rewarding hospitals who implement best practices. QHIP continuously reviews hospitals' inpatient safety, healthy outcomes, and patient satisfaction scores. Our outcome measures are compared to many hospitals across the country that are close to our size and our census. Each month, our leaders review our QHIP scores to determine what adjustments or interventions may help increase our scores and, in turn, our reimbursement. Last year, this facility alone lost $90,000 due to a proven hospital-acquired infection. That was one infection. This gives us a goal. That goal is to stop hospital-acquired infections. Galatians 5:13 says, "You, my brothers and sisters, were called to be free, but do not use your freedom to indulge the sinful nature. Rather, serve one another humbly in love." How does this apply to our role as nurses? It is our mission to always provide excellent care. It is time for us to advocate for our patients and reduce our number of catheter days, which will help in the reduction of infections. Some of the causes of catheter-associated urinary tract infections are catheters being placed in the emergency department without clinical indication. When the patient is accepted as an inpatient, the catheter is not addressed by the healthcare team. Another cause is that catheters are not being removed in a timely manner. In some cases, this is due to the nurses having to wait for an order from the physician to remove the catheter. A cause and effect analysis at Englewood Hospital and Medical Center revealed that prolonged periods of urinary catheterization was a potential target for intervention. The purpose of the analysis was to decrease the duration of urinary catheter use and ultimately CAUTI rates. A nurse-driven protocol for early urinary catheter removal was implemented to allow nurses to remove urinary catheters without an order from a physician. At the time that the patient no longer meets a set criterion for the urinary catheterization, the nurse was able to remove it without a doctor's order. The intervention included education of nursing staff and physicians regarding indications for indwelling urinary catheter use, alternatives, and bladder scanning after urinary catheter removal to ensure patients were not in retention. Quarterly CAUTI rates and urinary catheter utilization rates were measured and compared to baseline pre-intervention rates. 4-month post-intervention outcomes measures were calculated for the 3 months prior and compared to pre-intervention data. Urinary catheter utilization rate was decreased from 18.5% to 15.9%. The catheter placement life cycle begins with its initial placement, continues when it remains in place, ceases when it is removed, and may start all over again if another catheter is inserted after removal of the first one. By preventing unnecessary and improper placement of indwelling catheters, which is the most important strategy in prevention of CAUTIs. By maintaining the awareness of proper care of catheters in placement, by speaking up and prompting catheter removal, and of course by preventing catheter replacement, we can help in breaking this cycle. According to an article in BMJ Quality and Safety, educational interventions to improve appropriate use and clinical skill in catheter placement are important in the prevention of CAUTIs. Interventions such as catheter restriction and removal protocols are key tools to use in the prevention tactics. CAUTI prevention has proven challenging for several important reasons. Monitoring urinary catheter use and CAUTI rates to inform and sustain urinary catheter-related interventions is very resource intensive. Improving practice regarding urinary catheter placement and removal requires interventions to change the expectations and habits of nurses, physicians, and patients about the need of urinary catheters. We have several CAUTI prevention techniques that we are already using, but there is always room for improvement. Using an insertion checklist, counting day number 1 of catheter even if the patient has it placed at 11:59 p.m., and assessing catheters every day for removal, plus using our safety cross are ways that we are trying to prevent CAUTIs. Indwelling urinary catheter insertion checklists are used as a guide to make sure all steps are followed and that sterility is maintained. Another tool we use is the safety cross. This serves as a visual that shows how well we are doing with prevention. It also serves as a reminder to nurses about the criteria for catheters. It is up to us. We need to protect our patients. Psalms 18:35 through 36 shares the words, "You make your saving help my shield, and your right hand sustains me. Your help has made me great. You provide a broad path for my feet, so that my ankles do not give away." It is within us to be a part of a team that achieves excellent results through effective collaboration that will assure positive patient outcomes. That brings us to some great news, the introduction of a new urethral catheter removal protocol. This protocol will take the place of the existing protocol. This needs to be done because we need a clearer understanding of the appropriate use of an indwelling catheter that is more accurate reflection of the CDC criteria for maintaining a catheter. The new protocol will provide clearly explained criteria and will allow the nurse to remove the catheter without a physician order if criteria for the catheter is not met. As healthcare workers in this hospital, we are invested in creating a culture of continuous process improvement. Process improvement enhances clinical quality and operational efficiency. An article by Wagner and Begin described the importance of healthcare workers speaking up for patients. They say that healthcare professionals often hesitate to voice their concern. It is important that we know how to encourage others to speak up. Using effective communication is crucial to improving patient safety for healthcare professionals. As frontline staff, we are in an exceptional position to observe early signs of unsafe conditions in care delivery and bring them to the attention of the organization. Practicing as a nurse allows us the ability to assess, diagnose, identify outcomes, plan, implement, coordinate care, teach and promote health, consult, evaluate, communicate, collaborate. So take this flyer and pass on the important role we will now play in the early removal of catheters. Raise the bar and stop that CAUTI.